Gaskiya ne, gaskiya ne. Mm, 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 mm. So it's hard to say. Alaikum salam. Alama. Mm, da na koyi. Ruwanka. Kai. Wala. Ya Abdullahi ne dawo yana gaishe ka. Mm. Na ba Abdullahi ba mata ai. To ka to ka ji ko kai aure ko kuma mun yi su dawowa zai to ba da baturiya. Gashi. Oh, gasa. Oh, barka fa kwana biyu. To, lafiya alhamdulillah da jiya ya can. Ga mutanen can. A suna da lafiya. Suna da lafiya to alhamdulillah.
Right. Thank you, Abdul Baki, Chairman. Welcome back, everyone. I'm not sure how many people have heard what is presented on the table, but I hope you've had a really nice lunch, even more than what is presented on my PowerPoint slide. Just to make sure that we are back and to confirm how many are in before we start, can I please also request that for people to just put in the chat box just to say hello, hi, just to make sure, drop anything really. Oh, yep. Thank you, Amos. Thank you, Vera. Thank you, Enoch. Yep. Thank you, Judith. I believe, Amos, you are not raising your hand. You are just meaning to trying to raise your hand in terms of Amos, your hand is up. If you want to ask question, by all means, but if not, just okay, you're just indicating you are here. All right, thank you. All right. I think that's sort of a good number. And in that case, we will begin. So before we went on break, we are talking about different activities. Just since it's already 2 o'clock, so that I don't keep on dragging, or maybe I will finish this. Let's see. Oh no, maybe I will start. I will probably start the session with Vera's question. I will invite Vera. I think it's a good time to start with the question that Vera was asking. Vera, do you want to repeat your question here now, please? Thank you.
Thank you very much, sir. Can you hear me?
Yes, I can hear you.
Okay. Although you really talked much on in respect to the question, but I will still ask.
Yes,
I
please.
told you in trying to lift a dependent patient,
Okay.
and you tell the relative or the caregiver to please assist you, and the
Yes,
person will be like, is not
it's
his
your job.
duty, that is your job.
Yeah,
What will
yeah.
you do in such situation?
Okay. So the patient relative, by all means, they are not compelled to assist or help you. It's sort of your job. And I will probably start in terms of, do you want a picture of the capability of the patient? What is the capability of the patient?
Let me say,
So when you say dependent, what's the lower limb muscle strength? Can the patient roll from side to side?
not really, not really. And if you check the weight of the patient compared to yours, you know that you cannot even like carry the patient at all.
Okay. So the patient cannot roll from side to side. What of the lower limbs? Do you have any strength on the lower limbs?
No strength.
What's the condition, just to ask?
It's just like, let me say, a spinal cord injury.
Okay. So spinal
Yeah.
cord injury, is it so
Mm.
the it's lower limb that is
Um,
both lower limbs? So he has
both
upper limb strength.
limb. Yeah.
Oh, that's good. That's good start. How much of the upper limb does he have?
Let me say three.
Okay.
Yeah.
Three. Okay. And in terms of the trunk, I know you said he can't move the trunk, but I would imagine he's having some strength going upward, uh, above the point at which the affectation happens. What is the level of the spinal cord injury affectation, if you know?
Can't really remember now.
Okay, well, that's fine. So what I would say in this first is, if you find yourself in this situation, uh, now you don't have to lift a patient on the first day you've seen them.
Mm.
Sometimes it might be that you want to build them from where they are to where you want them to be. And if
Okay.
they have upper limb strength, I would say you begin with the upper limb strength. The lower limb, is it flaccid zero or there is any movement?
It's flaccid.
Okay. So for the upper limb, and they don't have any equipment that you can
No
use?
equipment, that's the thing. Yeah.
Okay. So for the upper limb, what I will encourage is without seeing the patient, and if you are alone, is try to build your upper limb strength. Try to see if you can start by just bed exercises, upper limb strength, but progress to bed rolling because it will help you in the what do you call it, in trying to transfer the patient. I didn't know. Do you want? It depends if you want to transfer him to sitting down or to the other bed. So if you work on the upper limb, the rolling, I would imagine with somebody power three, they can be able to pull from their side. Okay, so they're
Yeah.
trying to reach. Can he pull from side to side?
Yeah. Yeah. Yeah.
Good. So it's in my PowerPoint. As you can see my PowerPoint, I know you don't have equipment, but just the one you are mentioning is a typical example where I will use what I call bed levers. Okay. So bed levers is what is on the PowerPoint, is that frame that it's been tied around besides the bed. And the patient
Mm.
can use that as a fulcrum, trying to hold themselves using the hand and pull. Now, if
Okay.
I'm using a bed lever in this situation, I would, from rolling, and I've started my point already. That's a good case. So if I'm rolling a patient in bed, what I will do is, apart from my bed exercises and other things that I will do, I will recommend for the patient. When you are about to roll a patient, I will roll their head to the side at which I want them to roll. Okay. So
Okay.
I'm just preparing them in that direction. I will bend their legs the opposite to the side they are moving. So if they are
Okay.
moving to the right hand side, I will bend their legs, lower limb on the left hand side. Remember, I talked about using the ability of the patient. By bending their legs, now I will now, because it's a spinal cord, and I will imagine they don't have lower limb strength. I will be focusing my attention or my effort towards stabilizing the opposite, the left lower limb. Now I will ask the patient to use their hand, either the opposite hand, which is on the left hand, to reach across. If I have a bed lever, and I will talk about in case we don't have, if I have the bed lever, I will ask the patient to reach across to this bed lever. Or if the patient can't, I will ask him to use both hands, including the hands on the right side, but preferably the hands opposite. And then he will try to pull himself opposite. Now, once he's trying to pull himself, I'm probably back to you, Vera. Would your patient, I'm not saying doing it all together, do you think your patient can be able to make the effort of pulling himself if he's holding something like bed levers? Good. So good. So when he's holding and pulling himself, whether he can complete it or not is not the point at this stage. Now he can do it. I can decide to use this as a therapy whereby I'm encouraging bed rolling, trying to pull himself, trying to enable him, activate him to be able to roll. But if I want to see if he can roll, or if I want to complete rolling, what I will do next is I will find the most heaviest point. Now, I can stabilize the opposite leg either by sitting beside the bed, just at the bottom of the legs, because if you, from what you are describing, the patient's morphology is quite big. So I will not necessarily use my hands. I can decide to sit beside it. And there are ways you can do that. You don't have to bring your body in contact with the patient. You can use pillows in between the patient's leg, as well as the point of contact in your body, and just to create that up, so that you don't have direct contact with the patient's skin depending on their texture. Sometimes just for the comfort for the patient as well as for you as well. So I can put pillows. While the patient is pulling, the pelvic region is another heaviest point because he has taken away the pectoral girdle, so he can be able to push his pectoral girdle. My attention will focus on tilting the pelvic region, and just a little gentle push around the pelvic region will enable the patient, depending on the ability, to be able to roll on the other side. The opposite leg is bent, the right leg is flat, pulling using the hand, patient assisting you, and I can ask him I just tilt and then a gentle push on the pelvic region. Now I'm not, it's a gentle push, and then using biomechanics, the patient will be able to roll to one side. The question is, do you imagine this is possible in your patient?
Yeah.
Yeah. So I will encourage you, think of now if we have bed levers, so is pelvic tilt applied around the pelvic region. Once the opposite leg is bent, planted on the bed so that it doesn't slide, a gentle pelvic tilt, ideally is a two-man procedure, whereby your assistants or somebody can, if the family members are more than happy, you can direct them to help you support the patient leg, not moving him, just to plant on the bed, and you do a gentle push on the pelvic tilt. Now, if I'm doing that, I will recommend, it depends, because you have to be mindful the patient doesn't roll off the bed. You can stand in front of the patient, the direction at which he's pushing, is moving, to make sure that you are there to protect, or the family member stands in the direction at which he's moving and you are on the opposite side. Or if you can decide to, yes, just so that, but if he's conscious and you think he can't move, and you are the only person, you can go to the opposite side and give that gentle push. But preferably, best practice, you stand in front of the direction at which the patient is moving, so that he's coming and you are securing the patient, giving the patient assurance that you are always there to support them. Now, that is just the movement once. But if the patient has done it once, that doesn't mean they will do it again. That doesn't mean that they will do it with their family members. Now, this is where your responsibility comes in as a therapist to train the patient in getting that ability to be rolling. And like I said, you can break it down by just apart from the other bed exercises, by just doing the attempted roll. You can break it down. When the patient goes back, goes into that sideline, the patient can come back, sideline and can come back. Now that will be the first step of rolling. Okay, and then there will be a conversation on how you can build the patient ability from rolling to one side to the point of sitting at the edge of the bed, and then to taking him out of the bed. And back to you, Vera. What do you want to do with the patient? Is it just to roll him or to sit him at the edge of bed?
Rolling and sitting at the edge of the bed actually.
Okay. So especially neuro patient, it is a process, and sometimes it might take a bit of time. But there is no point, there is no reason if the patient is engaging, it is possible, especially with 3 upper limb, and if there is no any other underlying condition, it is possible to walk through the patient. Depending on the severance at the level of the spinal cord, it might be that the lower limb might not come back, but still you may be able to empower the patient to live as much independent as possible, whereby he can roll and sit out of the bed. My next slide will talk about sitting, but I can run through the example, your question, and then I will go through my slide. So the second one is once the patient is rolled on the side, let's say on the right side, now it depends from that position, I will practice more with him. It depends on the equipment available. Even with the rolling, if you don't have a bed levers as shown in the picture, you can think of using bed rails or any cord, any object at the side of the patient bed, or you can think of fabricating and attaching any support system, where, especially for your patient, because you don't want the patient to keep on lying supine on their back, and you don't want to be the person that you will always want to push the patient. So for you as a long term, I will highly recommend thinking of something like this so that the patient in their own time, they can sort of be practicing, and maybe the family will be able to come along and see because if they see something like that, they are not heavily involved. It will be the case of them using it with the patient. So once the patient is rolled on the side, you can sit them at the edge of the bed. Now, it depends on the patient's ability. It might require 2 or more people. It might require different pieces of equipment. And we will look at that. I think probably I will come back to that so that in my subsequent slide. I hope I answer part of your question, Vera.
Yeah, yes, sir. Thank you very much.
All right. And just to mention at this stage that what I do understand what I'm talking about is theoretical. I will mention it now and probably at the end of today's session. The practical session, if you attended today's session, you can, in the practical session, I'm planning the practical sessions on handling next year around possibly March, but it will be in Gombe State. So there will be practical sessions around March, and I will come along with some of those equipment for the practical sessions. It will be possibly in the FTH Gombe, but that has not been finalized. I just probably say, let me put it out there. I'm speaking with the hospital to arrange something like that.
And one can attend via virtual?
Well, we will look into that if you want to attend virtual. It is possible. I would like, if you are interested, you can drop in your contact. We have a moderator. You can drop in your contact in the chat or in the WhatsApp, and we'll look into the possibility of physical. Although I tend to recommend face-to-face, because with face-to-face, you will do it yourself, and then I will give you feedback. But I do understand that it might be difficult for every single person to be on site face to face. So yes, we can consider the virtual. Okay. Yes, you can drop in the chat in the WhatsApp I think we have is Adamu on the platform. NSP Gombe
Yes,
is
sir.
Adamu. Yeah,
Yes,
okay.
sir. Yes, sir.
Okay, can you please take notes of those that have started indicating the interest? If anybody is
Yes.
interested and reach out to them, please, when we are wrapping up sending them the certificate. It's going to be around
Okay.
March period for the face-to-face session. So let's come back to our slides.
I wanted
Yeah,
to ask a second question.
yes,
Sorry.
please, by all means. It's
Okay.
good. It's good. Ask the
This
question.
is in respect to risk assessment in
Yes.
regard to the environment.
Yes.
So I wanted to ask, is it advisable to have a tiled floor or just a cemented floor?
That's a good question. So sometimes, especially with the environment, we don't choose where we find ourselves. We just have to make best of where we find ourselves. And that's part of risk assessment. Because the important thing is to identify the hazards and try to minimize it. Now, the risk with tile floor is, from my knowledge, it has tendency to be slippery. Some of those shiny, beautiful floor that is good for us when we are young, but I think it's a risk to the elderly, especially when it's slippery.
Yeah.
Slippery both in terms of walking, and slippery both in terms of when they are using mobility aids. And this is where also your risk assessment comes in. Because if you find yourself on a tile floor, then you need to think of the object you are giving your patient, the grip, the ferrules. Some of those equipment have the ferrules. What is the grip? And secondly, if your patient is walking, and this is where your risk assessment comes in, I will consider the type of footwear they will be wearing in the house. Here in the UK, there are grip socks. So there are special socks that have some grips underneath them, whereby it's non-slippery. So if you happen to find yourself, like I said, we don't choose where we operate. If your clinic that's what is it, tile floor, then you may want to, and I think it's for the benefit of the patient, because having a falls and having a fracture, it costs a lot than having a pair of grip socks or some equipment like that. I'm not sure how accessible is the grip socks in your locality. Have you seen the grip sock? Just to ask,
No,
maybe Vera, have you seen
no,
do you know
I'm
what I
not.
mean? Okay. Has anybody come across what I mean by grip socks? Socks that grip in terms of risk assessment. Do you want to put in anybody? Okay. Idris says yes. Okay. No, some say yes. Mike say yes, but I guess Mike, you are not in Nigeria, so it's difficult to know. Idris, are you in Nigeria? So you mentioned about share with someone who flew, okay, airplane. Okay, so okay, you're talking about sharing it, because I want to ask in terms of where to get it, because I will recommend having grip socks for your patients. It will help them to minimize the risk of falls as part of the risk assessment, and it's part of the strategies you will put in. Okay, and do you know where we can access those grip socks? Because if it's something that I can certainly consider in my physical training, I can add to the list of things that I will be, if there are need for it, that I can bring it to Nigeria. So these are so forget about the dots on the back of the floor. So I've put it in the chat box. So what you see is that at the sole of the socks, you can see some uneven surfaces, some materials that they tend to put, and it helps the patients and prevents them from falls. Here in the hospital, it's part of the recommended practice. All patients, and it's irrespective of the floor they come across, if they are risks of fall, they will give them those grip socks because they have tendency to walk barefooted in the hospital. So if they are walking, they will use the grip socks to reduce the risk of falls. That's one example, Vera, regarding the tile floor and this thing. So, however, if you are on a cement, now it's also, while it's what sort of areas we find ourselves, but tiles might be more slippery than the cement. That's my imagination. I guess there are more surfaces that are more smooth as cement, but what you need to figure out is the slipperiness of that floor. The slipperiness of that floor. That's one. Second line in terms of your risk assessment is if your patient falls on those floors, what is the consequences for it? I will imagine a hard surface floor is not only breaking bones, they have high risk of injury. And that's what it depends on the setting your patient are. Sometimes you tend to consider carpets, so that while carpets have their disadvantage, especially with use of mobility aid, and that's why you need to balance. If the patient needs to use mobility aid, rocks are not best because they will get stuck. But if the patient don't use the mobility aid, a carpet tends to give that soft landing. And sometimes you don't have to put it in all of your house, hospital, clinic. It might be around the patient bed. And why is it around the patient's bed or in the patient bed is because research have shown that, and this is part of all the risk assessment, patients falls like when they wake up in the night, if there are no lightning, risks of fall, wake up in the night, they are rushing to go to toilet, going to toilet, risks of falls, wake up in the night, they are disoriented, risks of falls, they just get out of bed, even if it's not in the night, they are disoriented, risks of falls. So it's just to minimize the risks. That's what sort of things that you will do. So in terms of risk assessment, especially with the environment, it's identifying what is the risk and minimizing the risks. Yeah. I hope I answer your question, Vera.
Yes, sir. Thank you.
Okay. Still on this, is there anybody have any question? Thank you, Vera. That's a fantastic question. Anybody have any question, please? On what we've discussed in the morning, or anything really going forward? Or anybody have any patients that they want to share with us? Okay, that's fine. I will continue with my presentation. But at any point, if you have questions,
I'm not
please.
sure whether they are. So I'm not sure
Yes.
whether they are dropping the content. I can't see anything on my end.
Okay, not the questions. I mean, so there are people that are interested in the face. So there will be a face-to-face training sometimes at the next year. So
Okay.
it's not now on the platform. So now people have, I think there is Vera mentioned indicated interest, Amos indicated interest. So you can see it in the chat. I'm not sure, maybe it's only me that is in the chat.
Yes,
But
I'm not seeing their chat. That's why I.
Okay, maybe it's me that created a something different. That's fine. Okay, I would say they will. Can you please, for those that have dropped the message on the on whatever the section I tend to see on my own end, can you please drop the message on the WhatsApp group? Adamu will
Yes.
pick it up at the end. So drop the message at the end of today on the WhatsApp group. Adamu will pick it up, and when the NSP when we are sending them the certificates, we just ask them if those that are interested, they should indicate by replying or sharing their contact.
Okay, sir.
All right. So patient handling. Talking about patient handling, we start with bed maneuver. So the conversation now going forward is, I will speak from imagining your patient is on the bed. What will you do? Imagining your patient has progressed and is able to sit at the edge of the bed. What will you do? Imagine your patient is able to stand. What will you do? Or imagine your patient has fallen on the floor. What will you do? Or what are the best standard practices. So these are the 4 things that we'll cover: bed, mobility or bed maneuvers, transfers, sit-to-sit transfers or maneuver, sitting to standing transfers or maneuver, helping the patient getting up the floor or maneuvers. We have already started talking about the bed mobility, and I will refer, Vera has given us an excellent example of a patient who has a spinal cord injury. So I mentioned rolling patients on the bed. In terms of bed maneuvers, one of the main maneuvers we tend to do is rolling the patient from in the bed. Now, rolling from side to side, moving the patient up and down, or transferring the patient from the bed to the trolley, or moving the patient from the bed to sitting at the edge of the bed. So what type of patient needs this type of transfer, and how do we do it? Now, the first, talking about rolling patients from side to side. The patients that I will imagine will require rolling from side to side are the patients that are unable to do it themselves. Sometimes bedbound patients, we refer to them. Example is the X-year-old patient that Vera given as example, who had a spinal cord injury and has lost control of their lower limbs, but they have upper limbs 3 out of 5. And how you do that is how I described earlier. If I'm rolling a patient from side to side, if you are doing it for a care, and that is when a family are helping the patient. Now, you are not necessarily doing it from the therapy point of view. If the patient don't have the ability, now let me repeat, if the patient don't have the ability to help themselves, use their upper limb. Let's say the patient is lying and they cannot help themselves. What do we tend to do for a patient that is lying and they cannot help themselves? In our practices, what do we tend to do? I will ask, what do people tend to do in their practice if a patient is lying supine and they cannot roll themselves from side to side? So they are a bit lower, maybe muscle strength about 2 or 1 plus or 2, 3 minus. What do people tend to do? Or what do patient relatives, let me just say us, what do patient relatives tend to do from our observation or experience? Okay, turning them 24 hourly, yeah, 2 hourly. Okay. So the question is, how do you turn them 2 hourly? What is the processes at which you do the turning every 2 hours? So thank you, Vera. But what is the process at which we turn? How do we turn them every 2 hours? And what equipment? Let me go probably my next slide. Do we use to help us in turning them every 2 hours in our practice? Anybody have any experience? So turning them 2 hourly, absolutely yes. But how do we go about that? Either the nurses, either us or their family members, how do we turn them every 2 hours? Okay. So in terms of what I described earlier on, is the same process. However, this time around, because the patient is not able to move or subuse their upper limb as described earlier, this might require, standard practice might require 2 people doing the turns. 2 people doing the turn. So imagine a patient on bed, one person will be on the one side and the other person will be on the opposite side. One person will be on the left, another person will be on the right. The person first is the same process whereby you turn the head of the patient to the direction at which you want them to move. Because they can't use their hands, it depends what is the impulsivity of your patient, whether they are able to follow instructions or not. You can ask them to move their upper limb, the hand. Let's say you are moving them to the right hand side, move their right hand side away from the body, and then you use the other hand, which is the opposite hand, the left hand side, across them towards the direction at which you are moving. Then you bend the opposite leg, which is the left leg, in a flexed position like we discussed. And then you try to put your hands, if it is preferably 2-man lift, but you can possibly do it 1-man depending on the size of the patient. One of your hands will be at the pectoral girdle, so just across the shoulder, and then the other hand will be at the pelvic girdle, and you moving it towards your direction. The second person standing opposite will also place their hands just behind just the shoulder, just across around the pectoral girdle, and then the other hand around the pelvic, or you can advise the second person to help you with the lower limb of the patient, stabilizing it like we described earlier, and trying to push it in the direction of the movement. And once you put that patient in that position, you engage the patient by giving them clear instructions. For example, you tell the patient that they are going to roll on their right hand side and they should roll on the word roll. And the instruction will be something like ready, steady, roll. You followed, by the time you are saying roll, and both of you needs to move in sync, and you move the patient, you roll the patient towards your side. And by the time you roll the patient to that side, you can, for example, this is used in personal care, then the back of the patient is exposed and you can do your personal care from that direction. And if you are repositioning the patient, then from that direction, you can put your pillows or your wedges, positional wedges, where you adjust the patients and your pillows and everything to make sure they are comfortable. But if it's personal care, once you finished, you let go and the patient roll backwards to their supine position. If the patient can do it for themselves, I will encourage the patient trying to roll backward. But if they can't, you can bring them back. And you repeat the same process on the opposite side. So you reverse everything and you repeat the same process on the opposite side. When a patient is down on the bed, earlier on we looked at drag lift or drag lifting technique. So when the patient is down and you want to move them up into the bed, so the same rolling technique that I described earlier, you will use the same rolling technique to roll the patient. However, if you want to move the patient up and down, instead of dragging them or using the pillows, the bed sheet, if you have either slide sheet or drag sheet, when they are rolling to one side, you now fold the slide sheet or drag sheet and put it halfway through their spine and tuck it beneath them, and then ask them to roll back and then roll on the opposite side and tuck it beneath them, and then spread it. By that time, they will all be lying on the slide sheet. And then you can now, both of you on the opposite side, hold each side of the slide sheet with one hand at the pelvic girdle, the other hand at the pectoral girdle. One hand at the pelvic girdle, the other hand at the pectoral girdle. Now, depending if you want to move the patient, slide them all the way up in the bed. My recommendation is be aware that some beds have all those stopper at the top of the bed. Some don't. if your bed have stopper, be aware that you don't crush the patient heads on the bed. And how I tend to do it, I usually put pillows at the top end of the bed so that the patient doesn't hit that frame or bar or whatever you have at the top end. And then you slide at the sink with your opposite person all the way up or down. Or if you want to move them, so patient can maybe be lying close to the bed or towards one side. So if you are sliding up and down, you just move up and down. And earlier on, we described manual handling, how you can avoid turning, twisting. How you do that is if there are two ways you can do that. One is stepping, and if you are stepping, both of you will be facing each other, and then you take a step at the same time with both one hand on the pelvic, one down under the pectoral girdle, and you move up or down at the same time taking a step. However, if you are not taking a step, you can rock on your legs. So you take a wide stance and then you position your leg, the leading leg, I call it, in the direction of travel, and you moved the leading leg in the direction of travel. And that will avoid you rolling, turning, or twisting. That is if you are moving the patient up and down. But if you are moving the patient side to side, so maybe the patient has position, you want to reposition the patient to the midline, what you will do is you will, let's say, for example, you are moving your patient to the right-hand side. So the person on the right-hand side will be the one pulling the slide sheet. Well, all of you will slightly leave the up part of, so there are two slides. Sometimes the slide sheet have two parts. So the one at the top is the one that you will hold, and the one on the right will be bringing it towards the person, towards you, towards your own direction. However, you are not pulling the slide sheet towards you with your upper limb muscles. You are rocking. Remember, we talked about using muscles, using your leg muscles. Using your leg muscles doesn't have to be when you are bending downward. So all you need to do is you need to take a staggered stance, 1 foot on the front, 1 foot behind, and then you rock backward. So you are rocking backward with the slide sheet, not pulling the slide sheet with your hands. The other person on the opposite side, which is on the left hand side, will now push the slide sheet, gently push the slide sheet, will push on the pectoral girdle as well as the pelvic girdle towards the right hand side. And you will do that at sync. And one of you need to take the lead and give the instruction, ready, steady, slide. And it will be a smooth process. I appreciate it might not be as smooth as I'm describing. This is heavily practicals, but hopefully I'm making sense. Then if you are transferring patients from the bed to the trolley, ICU patient, for example, or accident A&E patient, or if you are changing patient bed, patients are lying down on bed and they want to change from one bed to the other, you can use either slide sheets. So all you need to do is bring the bed that you want to transfer the patient into it as close as possible, preferably at a lower height compared to the bed that you are transferring from. And in standard practice, you can use part slide. So part slide are those rigid frame that we used, in A&E to transfer patient. So the part slide is meant to bridge the gap between one bed or the other. And you have your slide sheet on top, and you just pull the same procedure that I described in terms of rocking from one side to the other. You slide the patient in your direction, the opposite person push the patient into the new bed. If you don't have slide sheets, you can still use your pillows, your bed sheets. If you have the part slide, and you put your part slide under the bed sheet. And how you put the part slide is the same procedure. You roll the patient to the opposite side and you put the part slide and you roll the patient backward. And then you put the part slide underneath the bed sheet, and you can use your hand, one hand at the pelvic, one hand at the pectoral, pectoral girdle. However, when you are transferring a patient from the bed to another bed or from the plinth to a bed, you will need more than two people, because you want one person at the pectoral girdle, one person at the pelvic girdle, and then the same on the opposite side. So at least you will need, standard practice, 4 people to transfer that. You may need more than 4 people, by maybe if the person does not have head control, you may need somebody supporting the head of the patient, and then you are transferring them from one position to the other. If you don't have part slide, then it's sort of the same technique, but it will be difficult because there will be friction. The part slide / sheet, their main purpose is to take away friction and make the movement easy. But even without those equipment, it is the same process of transferring patients from one point to the other. The last one, which I will be talking about, is if you are transferring the patient. I think so. On the picture, it's the bed levers. I will speak about bed levers. So the bed levers, there are different types of bed levers. You can put the bed levers underneath the bed, and then you put the patient bed on top, or you can tie it. It has a nut and bolt that you can tie it at the edge of the bed. If you don't have bed levers, there are some beds that have cots, more or less frames side by side. Think of using those frames side by side if they can hold the patient, and the patient can pull on those frames side by side to do their movement. If you don't have frames side by side, the idea is simple. Find a rigid object besides the patient bed, rigid enough that the patient can pull rather than pulling your hands. Rigid enough that the patient can pull rather than patient pulling you or their family. If you have any object as strong as rigid as that, then that will serve the same purposes. Then these are the slide sheets. They come in different shapes, size, or forms. And then the last one is the line from supine to sitting over the edge of the bed. So imagine we have rolled our patient sideways. Okay. Imagine we have rolled our patient sideways. So into a sideways position. If I want to transfer my patient to sitting at the edge of the bed, in standard practice, if you have all the equipment, let's say you have a profiling bed. So profiling bed is the bed that will bring the heads of the patient up by using a remote control. You can adjust the height up and down, or sometimes we call them ICU beds. But there are other ones for the ward. So you can simply tilt the heads of the patient into a sitting position. And from that sitting position, you can encourage, or even before the sitting position, you can encourage, it depends on the ability of the patient, encourage them to be in the sideline using the same principles, patient rolling, adjusting their legs, holding on the opposite side. And once they're in the sideline, you can tilt the bed slightly up to give them that advantage. And then if you have 2 people, one person will support their lower limb if the patient cannot move their lower limb. If the patient cannot move their lower limb, one person will suspend one of their hands around. So you put their lower limb in a slightly flexed knee, flex hip position, one hand around the calf region, just to give them that support. Make sure you support around also the knee area, one in the knee area and the other one just under the knee area. While the second person will support the pectoral girdle, and then you at the same time, ready, steady, sit, you move at the same time, while the first person, the one supporting the lower limb, will drop the legs on the floor, you will be supporting the upper body into a sitting position from that semi-reclined position. If you don't have a profiling bed and the patient can sit light on the side, you can ask the patient to turn to possibly their strongest hand, and then you can use that hand for them to bring the hand underneath themselves and push themselves up into sort of a, whilst you bring the lower limb out of the bed, the patient try to push themselves up and bring themselves into sitting. You are supporting them. Whether two people, one person, it all depends on the ability of the patient. If the patient still cannot do that in terms of, so once they are on the side of the bed and you adjust them. So once you bring them into the sitting position, you adjust them, you lower the bed and make sure their feet are on the floor. So by lowering the bed, putting their feet on the floor, you are increasing their base of support and you are increasing their stability. If the patient still cannot do that, then you probably would, in an ideal position, you will be thinking of using hoisting. Now we will look at hoisting in our subsequent slide. In the ideal position, you will be thinking of using hoisting, whereby you used a piece of equipment to practically lift them up and transfer them. You can use hoist to manipulate your patient in bed by either moving them up and down, sideways, in whatever position. When the patient is too big or large or bariatric patient, when the patient when the patient is morphology doesn't allow that, you can use hoist to readjust the patient. When the sometimes the settings, depending on the jurisdiction, it's recommended if the patient is totally dependent for you to use hoist, not to use your own effort to readjust the patient. But I will imagine hoisting is not something that is readily available. But it's just to bring to your attention that we can use that as well to readjust the patient. Is there any question on the bed-to-bed maneuvers before I move on to sit-to-sit maneuvers? Okay. Just to mention, I've admitted almost every person that tried to enter. I noticed there is one. I think Nuruddin Ibrahim has always been trying to join for the past couple of minutes. I think you probably have tried to maybe log out and log in again. I can see you've been trying several times. It's mainly around probably the network on your side because I've admitted you into the session. So moving on to sit maneuvers. So the question is, what options do we have? Okay, what options do you have? I want you to help me. So have a look at the PowerPoint. I want you to, oopsie. Okay, yeah. So I want you to help me in terms of what options do you have? So thinking of everything we discussed today. So the first part is, I hope you can see the slide. So the first part is patient has good leg strength, balance, and cognition. So leg strength, so their physical strength is good. They are able to follow instructions. You feel they will need a minimum to moderate effort from you in transferring them from one seat to the other, or repositioning in bed, maybe transferring them from one seat to the other. So the question is, what options do you think is suitable for this to transfer your patient? What option will you recommend? Either you to carry or to recommend your assistants to do for the patient. The floor is open. So patient has good leg strength, balance, cognition, requiring minimum. What option will you recommend? And you can unmute yourself. Yes, you can use the unmute function, please. And unmute yourself. What options will you recommend? Okay, assist the patient. Okay. So, yeah. So I think the conversation is you can transfer the patient manually because he can do it themselves. So it's just a bit of support. So yes, you can assist the patients manually. Now the second one is the patient has reduced leg strength, balance, and cognition, and you do not feel comfortable transferring them manually. What options do you have? I appreciate it might not be familiar, but I'm probably referring to standard practice, but by all means, I'm happy to hear the variations you have in your settings. But what options do you have? Let's say the patients have sort of reduced strength cognition, and you are not comfortable transferring them manually. What options do you have? Yeah, that's a good start. Thank you, Mike. Use of equipment. Any equipment comes to mind? So what equipment do you think, any equipment comes to mind that you could possibly use? Just transferring them from the bed to the chair or from chair to bed. Okay. Hoist, okay, that's right at the end of the spectrum. Yes, we can use hoist. However, if the patient is just a reduced muscle strength, it means that they have some sort of muscle strength. Hoist might not be hoisting is the last option in manhandling. So there are other options before hoist, depending. So if a patient is totally dependent, don't have any muscle strength, highly impulsive, then yes, hoisting will be the way. But let's say they have some muscle strength, they are not totally dependent. Thank you. Okay, use of frame, I agree. Yeah, you can use sort of frames. But yes, I appreciate in a certain context, but frames, yes, you can use frames. Transfer board, yes, Zalia, you can use transfer board. Okay. Frames, transfer board, possibly. And that also depends on the ability. I appreciate, yes, it all depends on the ability of the patient. There is what we call return type of equipment. So there are different equipment. So in our context, you can use frames, yes, but in terms of using frame, you have to assess all the things we've talked about. The problem with frames is if a patient can use a frame, then it's highly abled. Now, if a patient cannot be able to stand on their own, poor balance, they have reduced balance, they might be at risk of fall in using frame unless you support them a lot. And in terms of slide board, yes, you can use slide board, absolutely yes. But if the chair is close by, yes, you can use slide board. But also there is what we call return. So return is a piece of equipment for transfers, one out of many, where the patient will use their upper limb. So the red one is the return. So the red object is the return. The patient will use their hands. There is a hand handle, depending on height of the patient. They can use their hand to pull themselves. And then there is a part halfway through the return, the pad is meant for the patient to protect the patient's knee. The pad is meant to protect the patient's knee for the return. And all you need to do, if a patient is standing, even if they can't stand fully, that will support their knees, avoiding it from buckling. And all you need to do is just rotate that object from their bed. It can rotate almost 180, 90 degree, 360 to wherever you want to put them and into a sitting position. And once you've positioned them, you ask them to sit back in their chair. The next one is patient has, and apart from return, a piece of equipment, there is the rotunda, is also another piece of equipment. The same principles where they rotate. And with the return also, you can have slings. So slings are like belts. So think of these belts that all these people tend to wrap up, or probably fire safety people, maybe people doing scaffolding, climbing. So the slings that people tend to wrap around them or harness. So you can have a return with a harness. If you feel the patients have risks of falling back, and you wrap it around their pelvic girdle, some of them have a hook where you put it that supports them whilst they are in standing position. The next one is the patient has reduced leg strength, balance, cognition, and do not feel comfortable transferring them manually, but the patient is going to be transported over a short distance, for example, to the toilet. So maybe they want to transfer patient to the toilet. Yes, I know the easy bit is just transferring them and putting them on the wheelchair, and then you roll. That's an example. Or maybe or putting them on wheelchair and moving them. But sometimes there are pieces of equipment that you can use to transfer patient from one position to the other. And I think somebody mentioned that. So there is what we call Sarah Steady. I think the one with the blue is the Sarah Steady. Now the Sarah Steady, if you look at it, has a handle. Okay, the handle you can see is the one where you as a therapist will be holding. So the blue sort of a sitting frame is where the patient will come in from. So the handle can be flipped wide open. So all you need to do is you open the handle, not the handle, the sitting frame or the rest. It can be flipped open, and then from the sitting position, all the patient is there as a footrest. The patient will put their feet on the footrest, which is between the wheels of the Sarah Steady, and their knees will be supported by the cushion frame halfway through the frame, the Sarah Steady, and then you, the therapist, will be standing where the handle is. The patient will now pull. Usually there is a bar right across the where you are standing, just where you're holding it. In between those two bars, there is a bar that goes horizontally, and the patient will pull themselves. As they push themselves to standing, usually is a two-man lift. You have somebody who will now lower the sitting rest back into its position, and the patient can now sit back will sit in a semi-sitting position, and the patient will sit in a semi-sitting position, and then you can move the patient, from point A to point B. Okay. Abdullah, say my voice is slightly, is it decreased? Can you hear me now? Can I confirm you can still hear me in terms of my voice?
Yes, sir, we can hear you, sir.
Okay. So, okay. Abdullah, my voice is down. Okay, I will try to shout because I think my voice is high, but I will try to shout. Or try to increase the volume of your phone or laptop, but I will increase my voice. Yeah. Thank you for that, Umar Abdullah. So we have one. Just the last one is the sliding board, which I think, oopsie. So the last one is the sliding board, which I think somebody mentioned. Absolutely, yes, you can use sliding board for the patient. You can use sliding board for the patient. All this piece of equipment is subject to, of course, availability. And those piece of equipment, as a therapist, you are expected to make that decision based on your assessment, which one you think is most suitable for your patient. Which one is most suitable for your patient? So think of return as a transfer piece of equipment. That's the red one. Think of rotunda is sort of similar to the red one. Think of Serra Steady as a transfer piece of equipment, but this one where you can just move it in a short distance. The one with the blue color is the Serra Steady when you're transferring the patient. And think of slide board. I believe most of us are aware of slide boards, and that's why I probably forgot to put it on my slide, but I believe most of us are aware of slide board. So slide board is just as the name, slide board or banana board as we call it. It has a smooth surface. It's mainly used in spinal cord injury patients, but you can use it for other type of patient. It's not only for our therapy, but to enable the patient to function on their own as they move along. Any question on the seat-to-seat maneuvers? Or if you want me to clarify something or expand before I move on to the next one. Okay. So standing. Now, what options do we have also in terms of standing? So think of your patient again. Patient has good leg strength, balance, cognition. You feel they will need minimum or moderate effort. So apart from transferring the same thing that we discussed in my previous slide, you can use that in terms of standing your patients. So it's not only transferring from one piece to the other, you can use that in standing your patient. And why do I put standing? And if you look at, I put treatment. So in terms of my treatment, everything I've described in my previous slide, you can convert it into treating your patients. You don't have to create this fanciful gym and everything. So if you have any of this, the patient doesn't need to come down to the gym. For example, let me give you typical. So the, what do you call it? The Serra study. So I have a patient who is bedbound. So it means that the patient has not been out of bed for a very long time. When I first see the patient, I only do bed activities with the patient. Any other bed activities as a therapist you could do, depending on the ability of the patient. Free active upper limb, lower limb, SLR, straight leg raising. But because my goal, so your rehabilitation has to be functional for the patient to benefit from it. Strength doesn't necessarily translate to function. And that is another principle of neuroplasticity. It has to be task specific. So when you are training the body or the system or the brain, you need to train them also in that function that you want them to do. So when you give your patient activities for strengthening, think of how you can incorporate it into your function. So for this patient, what I do is the rolling from side to side. That's what we started, whereby the patient, all the person needs to do is roll, hold the bed levers and roll to one side and keep themselves in that position, counting. It is working on their upper limb and trying to maintain them. And then they come back to the midline, roll to the opposite side, hold that bed levers and counting. And then that's all. Just trying to translate into bed rolling. And then from bed rolling, I moved on to sitting at the edge of the bed, whereby I assist the patient to sit. Now, with sitting at the edge of the bed, we can do a lot of seated balance exercises. Now, this session is not for all those things, but just to carry you through the journey of what I will describe. So we move towards seated balance exercises, and sitting balance, all the balance activity you can do for a patient in sitting, from static balance to dynamics balance. If you are doing sitting activity, if your patient have reduced sitting balance, then you need somebody to stand behind them. You need to put pillows behind them if they're going to fall. But of course, you reduce the amount of support to challenge them. So the patient, I want the patient, my goal is for the patient to be able to recruit the lower limb muscles, all the benefits that comes with standing. You cannot, the standing is one of the best treatment I always push my patient to do. I use this SERA study. Now the SERA study is meant for transfers as well as standing, but I use this SERA study in my rehab. All I do is that I bring the SERA study close to the patient as I've described, and I raise the patient's bed because the patient doesn't have the ability to pull herself from a standard standing position, and I would not be dragging the patient. That will not be beneficial for the patient. So I raise the bed and I sort of shuffle the patient towards the edge of the bed. So having that increased height enables her to just try to come forward, and with a little bit of notch, the patient will come forward. And all the patient needs to do is pull themselves up into the standing, hold it to the count of 5, and then pull them back into sitting. Pull themselves up into the standing, and then you repeat that the number of times, and then you put them back into bed, and that's it. And these are all the things you can use those equipment for. Yeah, so SERA study can be used for standing as well as treatment, depending on what you want to achieve for your patient. But apart from SERA study, you can use return, but I prefer SERA study because it provides the safety. So once the patient is up, I can put the sitting rest back into its place. And if the patient is tired, they can just sit down and then come back up again, rather than going all the way back into the bed. Because at that stage, they are not able to do those things. And then I can increase the difficulty as time goes on by lowering the bed. Okay, before we move on to the next slide, which is the hoist, I believe. I will just talk a bit more about transferring patients sit to stand. Oops, a lot of people waiting in the lobby. Okay, I will talk a bit about sit to stand. Now, in terms of sit to stand, using it as a treatment and how you manipulate things. So when you want to transfer patient from sitting to standing position, the same principle we discussed. So first is there are preparation or consideration that you need to do for moving the patient from sitting to standing. One is foot placement. So think of what we discussed, shoulder width apart. If a patient is doing sit to stand, I would like them to have a stable base of support. I will make sure my patient's feet are not close together, but they are shoulder width apart. That's the first instructions. Secondly is slightly bending their legs just to give that advantage in down of knees, slightly below their sitting position. Okay, bending the legs slightly backward and make sure it's on the floor to give them that base of support. The legs should always be in contact with the floor. Excuse me. The legs should always be in contact with the floor. And then I will ask them to tilt their body forward. We discussed this earlier in the morning, displacing their center of gravity outside their base of support. So the description is, they won't understand all those big terminology. So think of a plane is taking off. So I want them to bring their head nose over toes. That's the term, nose over toes. So trying to bring their nose as far forward as possible over their toes. And then I will describe to them when they are standing, they will think of a plane coming up. So they should not stand straight. rather that they should go all the way like this, all the way up. So they should not stand straight, because once they are standing straight, they counteract their balance and they fall backward into the chair. So you want them to do like a plane is standing up. But again, if you instruct them to do this, then you need to be aware different types of patients, especially elderly, there is tendency for them to fall forward. So you need to think of how you manage that risk and what you need to do. So that is where your positioning comes in. As a therapist, I will stand beside the patient, assumed a neutral position, spinal neutral position, as we discussed earlier on, wide base of support to give me stability. I will move close to my patient. Depending on the amount of support the patient needs, one of my hand will be just in the front of the shoulder, in the side that I'm standing. I am not stopping the patient from moving, and the hand is not, of course, it will not assist the patient to move because it's in the opposite direction of the moving. The hand is there as a safety for the patient. The hand is there as a safety for the patient, and to reassure the patient that once they are doing the plane taking off, they're not going to fall off. I'm going to sort of give them that gentle nudge. Of course, if the patient, depending on the morphology of the patient, if you can't do that, then you need to think of other techniques as well as supporting, making sure the patient do it by themselves. And then the opposite hand, if they need a gentle nudge or supporting them manually, which is what we tend to do probably in low resource settings, my other hand will support them around their lumbar region, just to give them a nice gentle nudge. But I will encourage them to do most of the work themselves, and then they will use their both hands. If there is an armrest, if they can't, I will encourage them to use their armrest and push forward as far as they can. If they don't need my hand, I won't give them. But if they need my hand, I will give them that gentle nudge and they will move into that standing position. You stabilize them and then you repeat the same position. One of the biggest, and I believe most of you have been doing it as well, if there is any exercises that I think it's absolutely brilliant, is the sit to stand practice. You can ask your patient to do a lot of sit to stand practice. It will change their life. And you can manipulate sit to stand practice by altering the bed heights. So the higher the bed, the easier it is for the patient. The lower the bed, the more difficult it is for the patient. Okay, the higher the bed is easier, the lower the bed, the lower the surface is easier for the patient. The next one is the talking about transfers. So earlier on, I think there was a suggestion about using hoist. Absolutely, yes. We can use hoist to do our transfers. We can use hoist to do our transfers. Just a quick question. How many people have either used hoist or have come across hoist in their practice? Can you please say sorry to Ibrahim Nuruddin? I can see he has tried relentlessly to join. I don't. Please tell him that it's just the. I'm not sure. I've been trying to let him in. Yes, there's Zaliha. Do you want to tell us your experience of using hoist? What type of patients do you use it? Yeah, good afternoon.
Okay, mostly we use it for cord patient injury and
Okay.
at early stage stroke patients before they are strong enough for independent transfer.
Okay. And just stay with
Yes,
me, please, if you can. In terms of using it for early stage rehab, are there any things you consider before you use the hoist? Any checks, any risk assessment that you do that you
yes,
are
we do
aware of?
actually. Yes, we do. We check for alertness of the patient, orientation, consent of the patient as well. We explain the procedure to the patient so that he understand what is being done. Then also we check for orthostatic hypotension, whether the patient has high chance of getting orthostatic hypotension due to positional changes, and so, and also, what else did I remember? If there are sores, bed sores with the patient, we take that into consideration as well.
Okay. Thank you so much. And probably second to last, is there anything? So you talked a lot about the load. So we earlier on today, we talked about when you're doing risk assessment, there is the task, which is lifting the patient. Then there is the individual, you, the therapist that is doing it. And then there is the load, which is the L is the load, the patient doing it. And then there is the equipment. Is there any risk assessment or any checks or anything that you are doing in terms of the equipment, or are you aware of?
We do daily checks. There are, for where I worked, where we do daily checks, that's the therapy assistant is being done
Okay.
to check the hoist daily, the
Okay.
lubrication, to check the sling for any
Burnout.
if the sling is slack or not, whether there is issue with it, then you should, if it is battery operated, whether it's fully charged or it's not fully charged. So if it's not fully charged, you have to take it back to charge it. So he does the checks, but with the therapist, do the check before starts of the day. Before we start seeing patients, we do the checks to verify everything is in order.
Okay. Oh, that's brilliant. And the last one, and you don't have to answer. Do you want to take us the process of hoisting a patient?
Yes, I can do it.
Yes.
Basically, you have, let's say we're transferring a patient from bed to chair.
Yes.
So I ensure we have two people. That's the therapist with the therapy assistant, or if there's a nurse. If there's no therapy assistant, we use the nurse or the caregiver, whichever one is available. So two people is okay for a hoist. So what we do is physically we roll the patient to the side and insert the sling halfway. Then you now roll to the other side and you retrieve the other end of the hoist. So once it's fully secured, you make sure the head is resting appropriately and the shoulders are well protected. Then usually there are some that comes without wrapping the tie, and that's the lower leg. So you have to make sure you wrap the lower leg over the mid thigh, and both sides to make sure the knees are free. And when it's fully secured, most of the hoists have color codes, I think hangers. Yes, that you can use to attach to the sling hooks and to the hoist hook. So we determine that by the height of the patient as well. And I think with the weight of the patient too, predetermines that, but mostly is the height of the patient. So we attach it. Then one person, especially the therapy assistant or the care, if there is no therapy assistant or a nurse, the therapist will have to make sure the legs don't come in contact with the hoist during transfer. So you have to guide the legs and the pelvis as well. Usually some of them come towards the back with I think a handler for the around the waist. So you guide the pelvis and the person over it while another person is operating the hoist while taking it up. Then you safely transfer from the bed to the chair. So that basically that's how we do it.
Okay. And what informed your choice of the type of hoist sling you use? How do you measure? How do you measure the sling?
Basically, we use the height of the patient.
Okay.
Yes, because most of the times the therapy assistant is being trained. So we just send for the patient. So he brings in the patient, but usually it's the height of the, yes, we've already done the training for the patient. So, and for the therapy assistant, he's already trained on that. So he knows the height of the color code of the hook to use based on the height of the patient. So most of the times we're not there to observe the transfer because he has been taught. So he does it
Okay.
excellently well, actually. Yes.
Okay. And which setting is that? That's excellent description. Which setting is that?
That was a neuro rehab center in Abuja, neuromuscular rehabilitation center.
Okay, in Abuja.
Yes.
Okay. Well, that's brilliant. I think that's brilliant. Uh, exactly what you described. The only thing I will add is, so in terms of the checks on the hoist, like I said earlier on, jurisdiction varies. Usually in certain jurisdiction, there are usually somebody, so based on LOLA Act, lifting operations and lifting equipment, there needs to be an assessor for the hoist that come and physically check the hoist, but I think once a year or once in 2 years, in addition to the one you will do daily. So if you find yourself outside Nigeria or in other jurisdiction, always check there will be a date at which this equipment is serviced. So don't use it on patient if it's out of service. Secondly, the choice of the sling, usually you can use the color coding as described. Absolutely, you can use the sling, not the ropes around it, but the main parts that supports the patient from the occiput or just after the occipital bone, from the sacral bone, cervical region of the patient, to the sacral point or sacral region, sacral bones. And if the sling can cover that bit, it should be okay for the patient. So if you put it just there for the sling, that will be enough. That is if you can, but again, some patient you just need to do it, and based on the experience like described, because not all patient you can be able to measure it behind them. And in terms of transferring them back to bed, to removing the slings. So the only addition, how was described, is excellent. The only addition, removing them also, removing the sling. You Once you unwrapped the ropes around the lower limbs, you can just ask the patient. You can remove them, just removing from the underneath the thigh muscles for the patient, and you can ask the patient to lean forward, and you can remove it from, if they are in a sitting position, you can remove it posteriorly from where they are um, sitting down. And yes, slings, it's absolutely a good piece of equipment to have if a patient has significantly reduced muscle strength, balance, and coordination. However, like described, if you are using it, you have to make sure that the patient not only consent also, but also their impulsivity, because you don't want people hanging and then they start becoming erratic. That will not be a nice experience. Sometimes when you are moving a patient, they are asked to cross their arm across their body so that to avoid them holding and grabbing things. There are different types of sling. Oops, I thought this on my slide is not. So there are different types of slings. There is the mobile hoist, or sorry, different types of hoist, as well as different types of slings. So there is the mobile hoist. The one you are seeing in the picture is a mobile hoist. So whereby you can move it from point A to point B. What mainly is not used for moving patients, is meant for transferring patients from the bed to the chair, or from chair to bed, or to wheelchair. There is also ceiling tracking hoist. With ceiling tracking hoist, it's mainly inserted in patient rooms who are bedbound or in wards whereby you have, example, spinal cord injury or highly dependent patient in court, or in code. That's where you will use the ceiling tracking hoist. The same principles applied in the use of slings. Anybody has any sort of questions on sling and sling usage? Sorry, I cannot see the slide. Okay. Can people still see the slides?
Yes, we can see it.
All right, brilliant. Thank you. I think you probably need to, Ibrahim Gambo, probably try to rejoin. It might be some network. Any question on transferring use of hoist? Kim? Nope. Okay. So helping patient to stand. We come back around 1 o'clock, so it's almost 3:30. Okay. Now, hopefully we'll have some screen break at some point in a few minutes. So helping patients to stand. So how do people help patients? So you can use equipment to stand in, as we described earlier. There is absolutely nothing wrong with that. But this helping patient to stand, which you can use it for treatment, I think I described it earlier, is the same description I've given for sit to stand practice. So when you are supporting a patient, you support them through the pelvis that can through their pelvis. In terms of standing, put your arms across their lower backs. I know culturally it depends if it's allowed or not, depending on your setting. It's usually on the opposite direction, opposite side. And like I said, you put the other hand just to like a stopper in front of their shoulder region, so that when they are moving, so it's the same to stand practice, the same thing I described, foot placement, making sure that their foot is shoulder width apart, legs slightly beneath where they are sitting, displace their center of gravity in front, ask them to come forward, nose over toes, that's the word they tend to use, nose over toes, and imagine themselves like a plane is taking off. And as they are moving, you support them in terms of the standing position. And depending on the need you can support them. If they don't need it, you don't need to support them. They can do it themselves. Those that are able, we don't need to do even anything. They will just stand up by themselves. And you can incorporate it into your therapy as sit to stand practice. And in terms of walking patient, if you are walking a patient, I appreciate sometimes we just ask the assistants to do it, but if we want to mobilize the patient, if we can train also the party assistants, but if they are trained, brilliant, but you can use it in your therapy session. We stay close to the patient if you can, not take away all the. So when you're staying close to the patient, you are not necessarily holding them or taking away all their effort in walking, but it's just to reassure them and give them support when needed. You stand by their side. I probably don't have a picture, but I think most people probably, you stand by their side. You don't, if you're supporting them or if they are giving you their hands, you don't clasp your hands with them. Try not to clasp your hands with them. It depends on the amount of the supports they need. You can put wrap your hand in their opposite waist region or not. And this, you can also, in some settings, they use handling belt just as a support, not to drag the patient. And you giving them your hand to just rest, sometimes it's just the feedback they need. It's not that they are using it to hold themselves, it's just the feedback they need. And you can 100%, guys are expert. I won't talk more about it. The next one is the equipment. I believe this is our bread and butter. You will make a decision about what to use, when to use, how to use it, the pieces of equipment. So there are a lot of pieces of equipment that you will use to support the movement of your patient. I think hopefully most of us have access to this and we are using this for our patient. Well, in terms of risk assessment, what I want to realize, to mention is the same principles we are taught, appropriate height of the equipment to support the patient, checking the ferrules, making sure it's not worn out. Earlier on, I think Bevera asked the question about slippery surfaces. So think of how this equipment will be used on those surfaces. It's not enough for us to give those participants, the patients, those equipment, but we need to recognize how will they be using those equipment, in what settings. Because equipment that we may give in the hope that it will help them, it can turn around not to be helpful to them because it's interfering with their function. So make sure you appreciate where they will use it, how they will use it. I've had patients in terms, especially patients in the community, whereby when you see them with an equipment like this already. But when you start asking them the question or you look at the equipment, they will tell you that it is their neighbor that just give them out of their generosity. And because so you will know that, because you will see that the height of the equipment is not appropriate to them, or you will see that the ferrules is worn out, all those things. So as therapists, I think it falls within our scope to look at for those in risk assessment, as we instruct our rehab assistants or whoever that caregivers, caregivers advise the caregivers or the patient. Sometimes it's your outpatient clinic. The patient just strolled into the outpatient clinic and you may just feel like, oh, they have a piece of equipment, they are working, that's it. Just have a glance through the piece of equipment, make sure that it's right for them, it's appropriate for them. And you can advise them if it is not. You can arrange for adjust it for them if it is not. You can help them identify the risks if it is not. Our falling patient. Now, how many people have a patient ever fallen in your hand, and what did you do about it? Either in your therapy, maybe not patient, family members, therapy. What did you do about it? How many people have either come across a patient falling, or seen it or hear it? What did you do about it? What are your thoughts on falls and falling patient? And what do you do in your setting when a patient falls? I guess the obvious answer is that you just tell them, let them get up. Tashimana. What did you do? What sort of things? Anybody in terms of falls and falling patients? Is there other processes, procedure in terms of falls and falling patients?
Allah ya jagora. Ashe ka jima da dawa Abuja.
Abole, yani.
Yes, I'm here, Mr. Ibrahim. You want to contribute on falls?
No. Maybe later.
Okay. Anybody has any comment on falls and falling patient, please? As therapists, I believe we have come across unwanted experiences, not necessarily patients, but in our care, but maybe. And what do you do about it? Come on, guys. I don't think you, in your X number of years of practice, you've not come across patient falling. Am I the only person that is not a saint?
Okay, I want to respond.
Yes, please carry on, sir.
So, in case of a falling situation, the first thing I would do is to assess the situation in terms of the risk.
Yep.
What could cause it, if it is preventable.
Yes.
And whether it is just as we have just learned from you, looking at the acronym, whether it is the load that is the problem, or the environment, or the whatever could have caused it, is what will be assessed, and based on that, I will use my judgment into how to address the situation.
Excellent,
That's what I can
okay.
that.
But sir, stay with me. What's your name, sir?
I'm Amos.
Okay, so Amos, and in terms of when the patient is on the floor, what will you do?
Okay, what I would do, still based on, it now depends if the patient um, has the ability to move the muscles and to sustain a
Yes.
particular function. What that means
Yes.
is, and the patient sit up, and the
Yes.
patient, assume probably um, upright kneeling and so forth, or
Yes.
patient can
Yes.
actually stand. But before I get to that, if after the
Yes.
patient fall, under assessment, is there any complication that has developed probably? Is there fracture or not? And so
Yes.
that. So assessing the situation is the first thing, and
Yeah.
I will now take a decision whether patient can continue to function in terms of maybe sitting up, and
Yeah.
then maybe needed an assistant or needed to actually be carried into maybe a device that can assist him based on whatever situation I've assessed in terms of if there is no complication, then um, helping the patient to stand or sit
Yes.
as um, the situation might need, what
Yes.
I would do.
Absolutely. Thank you, Amos. Yes, what you described is assessing the situation, ruling out the complications. Now, it all depends on certain claims. I know certain jurisdictions have a protocol whereby a doctor needs to come, consultant or doctor, it depends on the site to clear them. Certain jurisdictions don't. But let's say the patient is medically stable and you are all clear to get the patient out of the floor. Now, there are different ways they can get out of the floor, like described by Amos. If the patient can be able to, we ask them to stand up. However, if the patient can't, sometimes it's all about thinking of how we can support them to stand up. Okay. Yes, piece of equipment like mentioned by Jennifer, absolutely yes. You can use piece of equipment. So there are pieces of equipment. Hoist is one of those pieces of equipment that you can use to get patient off the floor. So the same principle we described about hoisting, but this time around is from the floor, not from the patient's bed. And the same thing we talked about rolling the patient from side to side, turn them from left, turn them to right. That is what the same thing we will do. Put the slings, like described, I think, by Zalia earlier on, and then making sure they are held securely, and then we put the slings back into the hoist, and then we lift them up and then back to their whatever position that we put them. But apart from hoist, sometimes patient falls at home. We are not there. You don't want them to get stuck in the floor. Sometimes patient at home in our clinic, we are there, but we don't want to be dragging the patient out of the floor. There is what is called backward chaining. I believe probably people know. So backward chaining is a process where we facilitate patient to get up from the floor by using the surrounding. Just to ask again, anybody have come across backward chaining? Just as an idea, or has anybody used backward chaining for their patients, or are training their patients on backward chaining? The floor is open. Anybody have come across what we call backward chaining in helping patients from the floor? Okay, no. Okay, no, sir. Okay. Yeah. Backward chaining. Okay. So backward chaining is a process at which you support your patient to get off the floor without necessarily using a piece of equipment. Hoisting, yes. And sometimes backward chaining the patient doesn't have to fall for you to teach them backward chaining. And the importance of backward chaining is to enable the patient, even if they are falling on their own, especially elderly patients who struggles, their muscles doesn't allow them to be able to get up from the floor at home, rather than being sitting down on their own and waiting for help. All they do is, if they have fallen, irrespective of the position, is they can go back to a comfortable position. Let's say they are lying supine, facing up. The same principle we do in the rolling. So the patient would teach them to roll to one side. Let's say the patient will roll to their right hand side, and then they will use their right hand, pull themselves into a semi-reclined position with their legs bent. So the leg on the right hand side bent, and they will push themselves into semi-reclined position, and they will bend the opposite leg, and then they will move into 4 squats position. Then from the 4 squat position, usually we encourage the patient to move closer. So usually they should have what we called, we encourage them to have a chair, move closer to a chair, whereby they can use it as a support or any object close by. So from that position, you ask them to use their stronger leg into, so with the 4-point, from 4-point kneeling, they use their 2 hands and support themselves and put it on the chair or on the armrest of the chair that is close to them. And they move into 2-point kneeling. From 2-point kneeling, we ask them to bring one leg into like a standing position with the sole of the leg. And then at the same time, they rock and use the upper limbs and push themselves up into a sort of a squat position with the hands supported, and then they bring themselves up, straight up. So that's a way whereby patient can come up on their own. You can support them through that process of backward chaining if they can. Second option is, as from their 2-point kneeling, as they put their one leg, which is the stronger leg, into with the sole, like they want to come up, they don't need to go all the way up. They can just turn themselves and sit into their chair, and then from there they will stand up. This is a technique that they usually teach for elderly people living at home on their own, so that when they have fallen, or people that are high tendency of falling, they can get themselves back on their feet. And in your clinic or your assistant, sometimes patient, if they're falling, it's not for us to drag them. If they know the technique, we can just assist them in terms of bring them back into standing. But that solved the immediate situation. The subsequent one is risk assessing, as was mentioned by Amos, figuring out what causes their falls. Is it within them or outside them, and trying to fix what causes, well, not fix, improve what causes their falls. So yeah, use of equipment or not, you can able to help the patient get off the floor if, let's say, they are medically able. Now, Jennifer asked the question, do you teach the patient relative in case the patient fall at home? Yes, you do. Yes, you can. Or do you do this while seeing them? You can do both, but I think for me, so rehabilitation, it's about empowering the patients to do for themselves. There is no point if a patient can do things for themselves, 100%, I will give the ownership of everything to the patient if it is safe and doesn't require any specialized skills. There is no need for a patient to come and see me if they can do it for themselves. When they come and see me, I move on to other things. So I will teach, if a patient is at a regular risk of falls, I will teach the relatives to be using backward chaining at home for their patient. So yes, Jennifer. Anybody wants, is there any question? I can see people.
That one is what's wrong.
Okay. So maybe it's not a question. Okay. I think this is the last slide before we go for a break. So risk management or assessing therapeutic patient handling. We regularly handle patient as part of our therapeutic role, or we delegate tasks to other people to do it for ourselves. But when the treatment programs are devised, they involve such as this sort of manual handling. we are on different specialism, but all the main point is whatever we're doing, let's appreciate that the risks involved and figure out how to minimize the risk to ourselves, to the patients, as well as to the assistants that they are working for us. It might be a new concept in your setting, but believe you me, you can make the difference by empowering those that work with you in try to make their life better, in try to make their working conditions better. And I will stop here and ask us to go for our screen break, and hopefully maybe not launch this time around. We'll go for our screen break, and hopefully when we come back, we'll look at some case studies. We've already started looking at some, but we'll look at some case studies with regards to risk assessment and use of those equipment. So this is 3:50. Can we come back 5 minutes past 4? So this is 3:50 or 2:50. Can we come back by 5 minutes past 4? 15 minutes break also.
Yes, sir.
Yes, sir.
All right, thank you. Yeah.